Hi, my name is SteveJurch, and I'm the Director of Massage Therapy for the Women's Tennis Association, and I also teach continuing education through Jurch Performance Education. And I'm here to demonstrate some sports massage skills that I've utilized over my career. And I'm at Oakworks today with Nate, our model, and I'm working with the Boss table, which is a fantastic table, especially working with athletes. And so what I want to talk about now is one of the more common problems we see as massage therapists, and that's shoulder impingement or rotator cuff problems. Okay, and so if you recall, impingement is the painful contact between the glenoid and the bursa, subacromial bursa, and the actual acromion process itself. Sometimes you can actually impinge on the coracoacromial ligament, but that just depends on some other circumstances. And so impingement occurs, and over a long period of time, if that impingement is not corrected, then it can lead to what's commonly referred to as a rotator cuff tear. And the most common muscle affected is the supraspinatus. And the tendon, the tear typically occurs in the distal third of the muscle, closer to the tendon. And so you can have impingement and rotator cuff injuries from a traumatic incident, but more often than not, it's more of a chronic repetitive type of condition, and typically we see it stem from a lot of poor positioning in the shoulder, and what that leads to is improper biomechanics in the shoulder, and then that just creates undue wear and tear, and eventually you end up with a problem. And this is extremely common in the general population, but especially if you work with athletes, and even more specifically overhead athletes. And so what you'll see is the patient will come in with and complain of a deep ache in the shoulder. They can't sleep at night. They have trouble lying on sometimes both sides. And they'll have some radiating pain sometimes down into their mid-humerus and possibly up into their neck. Okay? So there are two orthopedic assessments that we can use to help gather information about this condition. And we want to be careful and very conscious of how we utilize orthopedic assessments, because we need to use them as massage therapists to gather information that's going to either guide our treatment, or it's going to help us decide whether to bring in another healthcare professional that may be more suited to help that particular client at that particular time. And so we're not using this information to make an evaluation or a diagnosis, because that's outside our scope of practice. And so the first test that I want to use is called the Hawkins-Kennedy test. And essentially what we're doing is trying to recreate that impingement position. And there's a couple of key points to this test that I'll point out as I'm doing this. And so what we do is we bring the client's arm up into about 90 degrees of flexion, okay? And then we flex the elbow to 90 degrees. Now here's one of the key points, is we want to make sure that the humerus is actually slightly abducted in front of the body, or horizontally adducted. So if we have the shoulder out here, for instance, we're not going to impinge on those structures, and so the test isn't going to be as accurate as it could be. So we want to make sure you're at least at 90, and better yet, in front of the body slightly. Okay, so you see this is your starting position. So you're 90 degrees flexion, 90 degrees flexion at the elbow, and a little bit horizontally adducted. All right, and all the test is we're going to support under the elbow, and then all I'm going to do is apply a force at the wrist. Okay, so we're internally rotating that humerus, and the idea is to create impingement in the shoulder. So a pain in that particular area of the shoulder is going to be a positive test. And so the key thing is to make sure that they are not, when we do the test, not dropping the elbow or not swinging the arm back out. Okay, we want to keep them in this position, so when we rotate the shoulder, we're going to get that positive exam. Okay? The next test we want to talk about is the empty can test, which is essentially a manual muscle test for the supraspinatus. Okay? And once again, positioning is important in this. And so if straight out to the side is 0, we want to have them forward of that to about 30 degrees. Okay? So the thumbs are turned down, and then we bring them up into that position. So we're 30 degrees forward of 0, and we have their thumbs turned down as if they were emptying cans out. There you get the name. So one of the keys with this is, if for the proper starting position, I want to hold his hands here, let your shoulders relax, and you can kind of see his shoulder just dropped. All right? And then I want to say, okay, hold your arms here. And then what I'm going to do is I'm going to apply a force to the wrist, and I'm just going to say, I'm going to push your arms down, don't let me move you. Okay? So I'm just going to apply a force, and we're going to test to see if there's an equal amount of strength on both sides. You can relax. Or if there's pain created in that shoulder. And we do that test like that because we want to generate an eccentric load on the muscle. We generate an eccentric load because it causes more stress, and so we can get a more accurate test. And so real quickly, again, if we bring them up 30 degrees forward, relax your shoulders. So his shoulders dropped. That's important. And then I'll say, hold your arms here and don't let me move you. Then I'll apply a force to his wrists. And if you get a weakness, so for instance, if the arm drops or if he gets pain in his shoulder, that would be considered a positive test. We have him drop his shoulders before we have him hold his arms because that prevents the deltoid from holding the arm up, and it's a larger muscle, so it takes over and it provides a less accurate result. Now, when you get the results of these tests, we want to look at it in a bigger picture. So we want to take into consideration things like the history, any observations that you've made, any palpation that you've done, and look at it as an entire picture. You can't just take the results of the test and then make your treatment decisions based on that one test alone. You have to look at the whole picture. Okay, so when we talk about treating from a soft tissue perspective, rotator cuff injuries or impingement, we first looked at the orthopedic assessments and we said Hawkins-Kennedy was more for impingement, and rotator cuff tears, we utilize the empty can test to test for those. And so there are a couple key areas that I want to focus on when treating this, and for completeness I would have released the posterior rotator cuff, the upper trapezius, the rhomboids, the latissimus dorsi. So I want to focus on some of the muscles that are sometimes left out or not thought of immediately. So I want to work on the pectorals, both major and minor, the diaphragm, subscapularis, and serratus anterior, and the anterior deltoid as well. So once again, a great technique that we can utilize is incorporating movement into our strokes. And so we can do both passive and active movements. Okay, so we can just start warming up pectoralis major. We can start incorporating, just relax for me, some movement to make sure that we cover all the different fiber directions in the pec major. And I can actually have Nate here. I just want you to do this movement right here. So he can now do it. And what we're focusing on is we're trying to get him to, we said that rotator cuff and impingement problems, all right, just relax for me, were an underlying cause was improper shoulder position. And so our strokes should facilitate that opening up and bringing that shoulder girdle back. And so we've warmed up pec major. Another muscle that often gets left out is anterior deltoid. And so we're going to start warming that up. Once again, we can utilize movement, so I can actually internally rotate his arm as I do a cross fiber stroke to his anterior deltoid. Anterior deltoid is a strong internal rotator of the shoulder and a forward flexor, so it is definitely a contributor. Okay, and I can actually have him do that movement. So go from here to here for me as I do the stroke. Okay. Okay, good. So once we've warmed up pec major, anterior deltoid, we can start to work into some of the deeper muscles. And so we want to look at pectoralis minor now. And so make sure that we've warmed up the border between pec major and pec minor. And then what we can do is we can access it by actually going underneath pec major. You can get to it through pec major, but this is a more direct method. It is more invasive, so make sure you stay within your client's comfort level. So what we're going to do is we're going to find that lateral border of pec major. And I'm going to take his arm and I'm actually going to adduct it and just rest it over mine. So he's just relaxing. Okay? So I find that lateral border. I start to go underneath it. And you can see how his shoulder kind of pops up by his ear. So what I'm going to do is actually depress his shoulder onto my hand. Okay? So once I do that, you can see how much further I can get up underneath pec major. Okay? So we're looking for pec minor. Then what we can do is start to move back and forth. Pec minor is a protractor and depressor of the scapula. And so we can kind of work back and forth on that pec minor. We can change the direction of our fingers to access different parts of the muscle. Okay. Once we've loosened that up passively, I can actually get him to actively engage that muscle. So what I can have him do is, I can have him make a fist, and then what I want you to do is just kind of reach your shoulder towards the ceiling while I'm just holding pressure and back down, and do that a few times for me. I'm just holding pressure on the pec minor while he's doing the motion. And the other direction we can do is actually have him do that same thing towards his feet. Okay, so my fingers are on pec minor underneath his major. He is depressing his shoulder blade, engaging the pec minor onto my fingers, working the muscle underneath my fingers. Okay, relax. Okay, so that is a very effective way to work pec minor. With active movement, the client is in control. So if it's uncomfortable to the client, they can stop the contraction. They can reduce the intensity of the contraction. And so it makes for a very effective method of treatment. So from this position, we can actually also start to work on subscapularis and serratus anterior. So I can put his arm in this position here and just start to work that lateral border. So we can work a little bit of serratus in this position. And we can work onto, when he's in this position, his shoulder blade peeks out from behind his rib cage. So we can get that lateral aspect. So then what I can do is I can get on top of or press down on the medial aspect of his shoulder blade, and then adduct his arm. And that shoulder blade will move back and forth underneath my hand. Okay, so we're utilizing a little bit of passive movement. Then I can have him do that same movement. So just keep doing that while I'm holding. And now he's moving that muscle underneath my hand. Okay, relax. Since subscapularis is an internal rotator, we can have him, I can hold that same position and internally and externally rotate as well. And then once again, I can have him take over that movement. So while I'm holding. Okay, relax for me. All right, the last technique for subscapularis in this position is I'm going to actually stand on the other side of the table. And we'll work on this more in the sideline position in just a minute. But if you don't have time to do that, or your client has difficulty lying on their side, what you can do is put their arm in this position here. And I can use the thumb to hook into that same spot that I was on. Take a deep breath for me. And then as they exhale, I can actually protract his shoulder onto my thumb. So I can get a little bit further back on that subscapularis. I can incorporate some passive movement as well. And I could have him do active as well if I wanted to. Okay. All right, so this is a one way that you can address the subscapularis. All right, another area that we want to treat is the diaphragm. And most people won't necessarily connect the two. But what I've found over the years is that people who have limited thoracic rotation put more stress on their shoulder. So diaphragm actually releases thoracic rotation and improves it quite a bit. So if we can release the diaphragm on that side and they rotate better, there's less stress on the shoulder. Okay, so while there's multiple ways of releasing the diaphragm, we'll just do one here. So we want to warm up that costal margin. All right, and then what I'm going to do is I'm actually going to utilize his breath to help do the stroke. So the first thing I want to do is I want to reach around. Now I'm going to refer to this as top hand and bottom hand. So I want to reach around the rib cage with my top hand, take the thumb of my bottom hand, find that costal margin and move about an inch to half an inch to an inch down. So we're not pressing right on that costal margin. Okay? So I'm reaching around with this hand. I've got my thumb just inferior to that costal margin. I'm going to have him take a deep breath. And as he exhales, I'm just going to pull his rib cage onto my thumb. And then I'm going to have him take a couple deep breaths. And so what I'm doing is I'm utilizing his diaphragm, his breathing, to actually push his diaphragm into my thumb, which is working it. Okay, so he'll take a couple breaths, and then I'll release. And then I'm going to move down and do the same thing. Go ahead, another breath, and let it out. So I pull that rib cage onto my thumb, and he's going to breathe. So he's doing the work, I'm just holding the position. All right, and then move one more time. And deep breath, and let it out. So as he exhales, we just hold that spot. He's going to take a couple of breaths. And relax. So then you can do a couple more. And that is a nice anterior work to help release that shoulder. Okay, so another great position to treat subscapularis and serratus anterior is side lying. And so we've placed Nate on his side, and we've already done that work from the anterior side, so we don't necessarily need to worry about warming up the tissue anymore. And so what we can do is we can support his arm under the elbow. I can take my thumb, and we can go anterior to the scapula. Okay, and it's very important that you're in front of the lats and also the teres major. Okay, so you want to make sure that you're anterior enough to get underneath the shoulder blade. Now, when I work on subscapularis, the focus of my pressure is up towards the ceiling because subscapularis sits on the anterior surface of the scapula. Okay, so we can really get underneath, and I can protract that shoulder onto my thumb. Once again, the pressure is towards the ceiling, and then I can start to incorporate some movement. I can do ab and adduction or flexion. I can do internal and external rotation, and then I can have him do that. So why don't you just move your arm like that for me, okay? So he is doing the work. He's engaging subscapularis. Okay, and relax. So once I find a spot, I'm not going to slide my thumb back and forth. Once I find a spot, I'm going to do the active techniques and then just move my thumb. Okay, so we can spend some time on subscapularis. And then the other muscle in this area is serratus anterior. And essentially the treatment is the same. The hand positioning is the same, except the direction of pressure is down onto the rib cage versus up towards the ceiling. Okay, so I'm going to use my fingertips this time. Find that anterior space to the scapula, and then direct the pressure down onto the rib cage. Okay? And then what I can do is once again protract his arm onto my fingers. Okay? Really get that serratus. Then I can have him engage that muscle, and it's a shoulder protractor, so I can have him just kind of punch while I hold that muscle. Okay? And depending on the client, they can control the level of discomfort. And relax for me. So utilizing active techniques is a very effective method to release those structures in the shoulder, get it in the proper position, and hopefully relieve the pressure and improve the mechanics, which will help the impingement or rotator cuff problems. I'd really like to thank Oakworks for putting these videos together. I'm very passionate about massage education, and I think these are great tools for therapists. I have some really interesting things on my website, and I'd love for you to check it out at www.jurchperformanceeducation.com. Thanks, and I hope to see you soon.